Good evening, everyone. I just want to get control of this before I really do the hard start. Good evening. There we go. I know it's going to echo me. So, good evening and welcome to Medical Mondays with Dr. O. Thank you, Dr. Craig. Dr. Toyin Opesanmi. I'm a family practitioner, HIV specialist, and I treat addictions in Maryland. I enjoy learning and also sharing knowledge so that we can better ourselves and better our health. Tonight, our topic is annual well visit or annual wellness visit and what you need to know. So some of us think that the annual well visit is overrated. And pardon me, I don't know the perspective that Dr. Aluya was coming from, but since we don't know where he is, we all do annual well visits, and this is a topic that by the grace of God, I can handle. So here we go. Some people think annual well visit is overrated, but really it is not. During the annual well visit is when we have the opportunity to actually dig into your past medical history, catch up on what we might have missed or didn't even know in the previous year if the person, the patient, is an existing patient. If the patient is a new patient, it is the opportunity to, actually get to know the patient, do what we call review of systems, meaning we ask all those questions that you're wondering, why are they asking these questions? Why do they want to know these things? We do that in order to know where to focus on you, how to treat you, what we need to pay attention to, and what we need to investigate if possible during that visit. So, what does the review of system entail? It entails asking from head to toe about your health. Do you have headaches? Do you have fever or chills? We call it constitutional symptoms. Do you have, abdominal pains, nausea, vomiting, stuff like that, leg pain, back pain. Some people come for routine wellness checks. And when we ask, do you have any problems today? They say no. But when we start asking all these questions in the review of systems, things start coming up. Then they say, yes. Then they tell us about the chest pain they have that comes and goes, that lasts 15 to 30 minutes and resolves, and then, comes again another time. And that is important. Or the headache that, they have that keeps them home for like 3 days sometimes, and, has nausea and vomiting with it. They can look at light and stuff like that. And we start finding things. We ask about past medical histories. We do that because it helps us to know what happened in the past and, again, what we need to pay attention to now. If it is important, if it is significant, and, what we need to do for the present time and going forward. We ask about past surgical history, again, for the same reason, but even for more. I have been called before by the emergency room surgeons to know if a patient has any reaction to anesthesia. If I didn't get that history, find out if they have had past medical history in the past, and if they had any problems with anesthesia, I would not know how to answer that. Family history, we've talked about that on this platform, that there was a strong debate on that why do you need to know about the family history? It actually helps us know if it's something that we need to investigate in the patient. For instance, if there is family history of high blood pressure or diabetes in the family, then we need to check when we check in labs to see how the blood sugar is, what it's been running then, and what it has been running in the last 3 months before that visit. That we call A1C, hemoglobin A1C. If there's thyroid problem in the family, then we may need to pay attention and, investigate on thyroid issues, especially if the patient has symptoms that could simulate thyroid problem, and the list goes on. So we also ask things about careers, how somebody is doing, where they live in, are they married, are they not? What is their living environment like? What is, how is their lifestyle? It is important to know these things for health reasons. And, it's, of course, specific to each individual, how we need to intervene in that. In my patient population, sometimes when we identify people who are homeless, we've been able to connect them to shelter and stuff like that. And that improves health when somebody has a roof over their heads. I mean, it helps them to be able to focus on the needful then, because then they don't have to worry about that housing situation. Jobs and all, we've been able to connect people. It's very interesting, the dynamics and things you see and you're able to do when you do this, physical exams or wellness checks, and you are able to ask all these questions and find, things that need to be corrected or, where one needs to intervene. We ask things about, habits, smoking, drug use, because we're able to intervene. As you know, I treat substance use disorder. And so for me, I'm very passionate about knowing, what somebody is using or not using. Then sexual habits, that I hate. Do you know, when I was in medical school and we were taught to ask about sexual orientation, I raised my hand up and I said, what's my business? Why do I have to go there? And especially when somebody is older than me, can you imagine? I'm an African. You have these people who are older than you, and I'm asking what their sexual preference is. Are they having sex with men, women, or both? That's the way I was taught in medical school. I went to medical school here in the US, and we actually had sex education class where we were, this is not part of wellness, so I'll leave that alone. But we have to ask these questions. Do you have sex with men, women, or both? I draw the line with animals. I don't ask that because I don't know how to intervene. If you're having sex with animals, I really do not know how to intervene. And one thing we were taught in medical school also was that if you cannot intervene, then don't screen. So everything we ask, the tests we do, it's because if results come back and needs intervention, we have ways to intervene. If we don't, then we don't screen, is the rule of thumb. So then we do the physical exam, check from head to toe. Sometimes, after all these questions, you would think that we got it. No, it is on exam sometimes that we pick up other things. I'm like, okay, when has this been there? And then be able to intervene. After that, then we do blood work because you see everything on the outside physically. There are things that we cannot identify without doing blood work. And, we'll check the needful. The history that we got helps us to fine-tune the types of labs that we need to get. I, though, have standard labs. I check all the basics, the blood sugar, the cholesterol, kidney function, liver function, the urine for infection. I check sexually transmitted diseases, even the ones that are not commonly checked. HIV, syphilis, gonorrhea, chlamydia, trichomonas, mycoplasma. I check them some in the blood, some in the urine. And depending on the history, other things may be needed to be checked, like the thyroid, like, hepatitis, and the list goes on that one may need to check. Vitamin D has become my routine to check in everybody because most people are actually deficient in vitamin D. So an average physical would last between 15 to 30 minutes, depending on how much history, how much talking is needed. And then, we wait for the labs to be discussed in 1 to 2 weeks. So that's what a wellness check consists, at least, for the general population, both men and women. For women, it goes beyond that. Then there's the pap smear that people like me, primary care physicians, internists, do in clinic. I do pap smear, but, OBGYNs also do pap smears. And in the pap smear, things are checked to make sure that, the health is good there. Cancer cells are looked for. Human papilloma virus, HPV, we talked about that even last week, is checked to make sure that, it's there or not there. Sexually transmitted diseases also can be checked during pap smear instead of blood work. We can do that. And then depending on age, different things are checked. We seize that opportunity during that wellness check every year to make sure that, for instance, you've had your colonoscopy. Colonoscopies, we used to start screening at the age of 50, but it's been brought down to the age of 45 because there's been an increase, an upsurge of colon cancer in our populations. And I say populations, not just a specific type of people. We've seen a huge rise in it. So the age to which screening starts has been decreased. Now, I talked about family history earlier. If somebody's father or mother, for instance, had colon cancer at the age of 45, we will start colon screening in that person at the age of 35, 10 years before. Just as an example, of why family history is important and some of the things that it leads us to check. So if you are on this platform and have not had colonoscopy done, and you are over 45, please talk to your physician, have one done. It's a lifesaver. I think it was 2-3 years ago, 3 people that I didn't know personally died that I got to know about. And they were all in healthcare. No, there were 4. One was a patient of mine. The 4th one, she was not in healthcare, but I looked in the chat and every visit, I noted that I reminded my patient to please get colonoscopy done. And we'll go over the procedure again to explain what it entails, how easy it is, what you need to do. And I'll talk about that in a minute. But she never did it. And that was what took her life. That was an unnecessary death. It was a painful one. The other 3 were in healthcare, nurses. Nurses, I'm not knocking you, but nurses have a way of just making excuses not to do these things. Colonoscopy is something that is, is not fun, Before I had my first one, I used to say, it's a piece of cake. You'll be sleeping. You don't even feel anything, which is the truth. You'll be under anesthesia. That is the truth. You won't know. And it takes what? 15, 20 minutes and you're done. If that, I mean, that's even long sometimes. They finish faster sometimes. But when I did my first one, I realized that the prepping is not the easiest thing. You know, you get to be given diuretic, something to clear you, to cleanse you out. You're going to be up all night, running from your bed to your commode. You know, be ready for that. The cleaner you are, the better. You need to be very clean so that when they go in, because what they do, you are clean, then you go in the next day. You go in the morning, rather, to the gastroenterologist, the GI doctor, to go get your colonoscopy done. They will put you under anesthesia. They would go with a tube through the rectum. Men have told me that somebody going into my rectum, heck no. And that's why they don't want to do colonoscopy. You'll be sleeping and it's not an abuse. There will be other people there, nurses, you know, and all those who will be helping the GI doctor. And you're not going to be abused. It's just a tube going through the rectum and going all through the colon to go make sure to see that the colon is clear. There are no little growths that we call polyps in there that can potentially, some of them can potentially become cancer if they're not removed. But guess what? If they see any of them, they take them out immediately. And that's a cure. Then the colon is cleared. Isn't that awesome? The colon is cleared. Depending on what is found, if they find anything or when they find something, they're going to send it to pathology. Pathology will look at it and let us know what exactly that growth, what exactly the growth is. If it's cancerous, if it's not, and based on what the pathologist says, the GI doctor would then recommend follow-up colonoscopy in 1 year, in 3 years, 5 years, or 10 years. So if nothing is found, your next one is 10 years. Isn't that awesome? So some people still have an aversion to this. There's some good news. In the past, we will collect this stool and test it for blood. If there's blood, then we'll explain that you really need to do colonoscopy. Because why is there blood in there? You know, there should be no blood. Cancer cells can cause one to have blood. And that's usually the symptom that people who already have cancer have. Usually, that's what they present with. They're seeing blood in their stool. So if you're seeing blood in your stool, there is a problem there already. It could be hemorrhoids. And those are totally benign, meaning that they're not cancer, they're not going to be cancer, but you know, they will be treated. That could be why one has blood in their stool. But if you have blood in your stool, please get it checked. So that was what we used to do. Now we have a testing called Cologuard. It also uses stool. The stool is collected. You're directed, you know, they send you this kit at home and you're directed how to collect the stool and you send it to the company and they would test it, use your DNA to know if there is cancer. They will say for sure if there is cancer or no cancer. So that's an advancement. But the thing is, if there is cancer, if it's positive, or let me say for cancer cells, or cancer, you know, if there is cancer cells, if it's positive for anything, you want it to be negative, but if it's positive for anything, then you have to have the colonoscopy because that's the gold standard. Sigmoidoscopy is not even a thing. I don't talk about that anymore. Sigmoidoscopy means that they put in that tube and they go all the way to the sigmoid. They don't go all through the colon. I mean, why would you do all of that and not see everything? Please look at everything in my patient. That's my take. You're in there already. go all the way around and let's see everything and make sure that all is right. So colonoscopy is very important. Now, mammogram in women. We talk about mammogram in women, and standards have changed there too. The standards that have changed is that we used to start mammogram early, at the age of 40 or earlier than some colleges are now recommended. My college, they family practitioners, the AAFP, and and some other physician colleges are recommending that you start mammogram. Some say 45, some say 50. The College of Radiology still says you should start it at 40. And I think the OB/GYN also says 40. Why is that? Because the radiation that the mammogram machine uses itself has the potential to cause cancer. So we want to decrease the amount of radiation that the breast receives. Getting mammogram early exposes the breast earlier. But then we have better machines now than previous that don't use as much radiation as we used to use in the past. So that's another good thing. Some colleges, as I said we should start later and recommend that mammogram be not done every year. It should be done every other year. The College of Radiologists says you should start at 40 and continue every year still. So that is conversation that a woman will need to have with their physician to decide what is best for that woman. There's also the option of MRI, which uses magnetic fields, does not use radiation, but most insurances will not pay for it unless there's a problem already and that is needed to further evaluate. So, but that option is there. I know some patients in my practice who decide to pay cash to do MRI some years and then mammogram, other years. Again, it's conversation that one should have with one's physician to make the decision that is best for that person. And again, these things are individualized. It would depend on that patient's history that would help one to make the educated decision. Men also can have cancer, breast cancer. So when a man presents with a nodule or a lump in their breast, we do evaluate with mammogram. That is not part of well visit, and it could be, because if I examine a man and they have a lump in their breast during their well visit, I'm not going to sit on it. We're going to evaluate it. And so it could be part of the well visit also. So I want to add that it is important to also do things like eye exams. If you start noticing your eyes are getting blurry and all, or you have certain disease entities, eye exams are important. People who have diabetes, high blood pressure, eye exams are important. Very, very important. At least to be done once a year. Dental exams. I've talked about that. We've talked about that on this platform. Dr. Ajagbe, Dr. Oyewole, they have talked about dental care. It is very important that we take care of our dental health. Why? Because it's been linked to cardiovascular diseases, to heart disease, to problems that have to do with the body. So that also is included in the well visit. So I'm going to now leave this to questions. And again, I didn't prepare for this talk. So I've thrown you what is necessary during a well visit. But what should you ask is the question. What do you need to know? I've addressed that. What should you ask is another question that I will put forward. Sometimes we physicians may not think of something. Please ask. If you ask, it will get done. Since you've known what needs to be done, if it's not done, it's not included in your well check, please ask. And I know that here in the United States, the physician would oblige you. So, Dr. Craig, you can ask your question, sir.
Actually, I'd like to just affirm what you're saying, and I'll say this by a mistake that I made, and the mistake in terms of doing the complete evaluation of a patient. You know, you have your form, you ask all the questions. There was one question that I did not ask. And I after I realized that it was unfortunate, it was sad, but I didn't realize it. Asking all the nutritional health questions, I did not ask about his living circumstance. And after giving him all of the information, I realized that the man was homeless. And how can I even begin to intervene with a man who is basically living in the streets trying to survive? The lesson was well learned. It taught me a lesson. And in my examinations and in my evaluations, I became very, very careful that I included everything that was necessary as you've just brought forward. There are some questions I have about the symptomatology. Sometimes if there is no symptom that is there, why are we moving in that direction? But then again, the tests are basically prophylactic. We're trying to find out if anything is there going on. So just affirming, as you brought forward, the importance of covering the complete base is critical. I would like to see more chemical evaluations done in terms of these things, but that can be expensive. And now we've got to go through insurance issues to make sure we get them done. But no, bringing forth the need for a wellness visit is critical, and I'm glad that it is part of your design in terms of speaking with patients, and I hope others are doing it as well. So again, thank you, Dr. O.
Thank you so much. That is very important, what you said. You know, it's important that we know where the patient lives.
Mm-hmm.
You'll be surprised. I have stories of people that are even professionals, and you'll be surprised of their situation. When you ask and they open up, it's incredible. And it gives them the opportunity to intervene. There are other things that we should ask. I'll let Dr. Izugu go first. And please, if you want to post your questions, you can do that in the chat box. If you would like to post your questions, you can do that too. Dr. Izugu, go ahead, sir. Please unmute.
Yeah, sorry about that. It's, I was muted. Dr. Ko, you really quite commendable to off the cuff really, present that. That was really comprehensive. Very much appreciated. So we do make it clear for our patients that annual wellness visit is just like, setting up the plan for the year, in what is needed for your care and when something may be due for and all that. And then we're going to remind you when it comes due for those things to be done, including the things you listed, mammogram, colonoscopy, whatever all the tests are. One of the things we actually do a lot too in part of our annual wellness visit, especially for our diabetic patients or those who have been exposed to either chemicals or alcoholic is really assessing for neuropathy, that we actually begin to question them on those and then begin to do tests to pick up early neuropathies and begin to, address them on how to prevent that from getting any worse. And then also discussing some of their risk factors and making some calculations and what puts them at the higher risk for cardiovascular complications. Because you're going to find in different fields, there might be things that you could do to make a big change in the overall prognosis of a patient. So you really use that as an avenue to discuss all different types of things. And it's so important that Medicare, of course, were the first to recognize how important that is and started paying doctors to do that for patients. And really, it's important to take that to every other insurance or non-insured patients in really making out that plan and making it clear that this is separate from your routine examination. And this is just for us to make a plan on how to take care of you in a preventative approach, which is the right thing to do. Because once you can prevent a disease, the complication rate, the cost of care, the mortality, all of those go down. So I commend the effort in addressing this topic. Thank you.
Thank you so much. Thank you. The cardiovascular aspect is huge. And in primary care, before we send them to you, Dr. Izugu, we do during the well visit, screen for the cardiovascular diseases, starting from the blood pressure.
Beautiful.
Even, the legs, we check the legs for swelling to see if they have swelling. We do that so that, if there are issues, we quickly shoot them to you. And, thank you so much for bringing that to the forefront again. You won't believe, though, that I missed some big ones. And, Mary, thank you so much for the reminder on mental health. Mental health is a question that, believe it or not, I pay attention to every visit now because there's so much mental health issues, especially since COVID. We've had issues with mental health in our population, but since COVID is, oh my gosh, it's been something else. So depression, bipolar disorder, these are things that are easy for us to catch during well checks. Depression is not a single, it's not a single symptom like blood sugar, for instance. The blood sugar is high. It is high. So there's a problem. It's diabetes. Blood pressure is high. On 2 to 3 occasions, we diagnose high blood pressure. Depression is different. It's a constellation of symptoms. Mood, sad mood, or agitated mood. What we call anhedonia, the inability to get up and do things that one ordinarily loves to do. So when we're asking the question, we ask, how is your mood most of the time? Is it happy, sad, agitated? Do you have the get-go to get up, to do things that you normally enjoy? Sometimes we would ask, what are the things you enjoy? And then ask if you have the get-go to do it. What about your sleep? Do you sleep well? Or do you have difficulty sleeping? Or do you even sleep too much? Because it can go any which way there. Do you overeat or have no appetite? That can go either way. Are you gaining weight or losing weight? Do you have guilt feelings? How about your memory? Is your memory good? What about your concentration? Are you able to concentrate on tasks? Some people cannot watch a whole movie. They'll fall asleep. It's a concentration issue. We can diagnose concentration by that. So, are you suicidal? You'll be surprised. I've had to call 911. The police has to come because when you do that for mental health, the police come. The police is actually the one that will take the patient out in handcuff I fought the police for them. I'm like, no. My patient was like, Dr. Oh, they handcuffing me. I ran out of, I said, why are you handcuffing my patient? And then one of the officers said, can I talk to you, doc? Took me to the back and explained to me that the patient is suicidal. They put the patient in the back of the car, of the police car. The patient can punch the glass, jump out. They've seen different things happen in that back seat. And that's why they have to do that. So I went to my patient to go explain exactly what I was told to the patient, and the patient was cool with it. But that was just in clinic. It was a routine clinic day. Can you imagine? Things got exciting and then comes down again. So we ask all these questions because we want to know if somebody has depression. They could have anxiety. Yes, and I see they're posted in the chat box, stress. We diagnose this. So depression is a constellation of symptoms. And if any on the platform have this, please seek intervention or reach out to me. You know that on this platform, we don't establish physician-patient interaction. We disseminate, information. So, but reach out. And you know what? I'll plug you into resources. Dr. Izugu, go ahead. You can unmute.
Yeah. So
Hey.
yeah, I just want to chime in on that because that's really very important. That's one of these questions that are really within the annual wellness questionnaire, which include, do you have a gun in your home? And if the gun is, you can go extra to find if it is housed or locked and stuff like that. People ignore that question, but it's very important. They feel that they shouldn't legally ask, but it's a very important question, especially when you're looking into this issue of depression. And sometimes if they ask you why, you just want to know if it is safe, locked, at least that the children, the people, everybody is safe. Is a standard, and it shouldn't be seen as a question of intrusiveness. Is there any gun in your home? Is it in a locked space? Something like that. Because these things can cause a lot of problems in places.
Thank you so much.
Mm-hmm.
Do you know that oh my gosh, that is so important. This happened, I think it was in California, the psychiatrist that a patient told that he was homicidal and canceled the patient, but apparently did not report it. And this patient carried out whatever he wanted to do. And the psychiatrist was held responsible. Those questions are important. We have to ask. So when we ask, don't get upset.
That's right.
Sometimes patient gets upset. They ask me, why are you asking me these questions? Or when they don't ask, when they don't say that, the body language is like, come on. And I stop immediately and explain why I'm asking each one. Then they relax. So now that you know, don't get upset. These are questions that, we have to ask to make sure that we are doing the right thing and that we're getting all the information that we need. So this is an unbelievable forum. Medical Mondays with Dr. O family, you are the best. In the forum, I'm getting so much help. I'm excited. So Dr. Famuyiwa said she believes inquiring about a patient's fertility potential has risen to the level of a primary care question. You are absolutely right.
That's correct. Mm-hmm.
You are 100% correct. Thank you. I love this specialist. Let me tell you what we do on our end. Like I told Dr. Izugu, what we do with cardiovascular issue. On our end, when we ask in that living area who the patient is living with, or where they live in, what's their highest level of education, what do they do for work? Those are questions, basic questions in well visit. We also ask how many children they have. And that leads to questions on fertility. The ones who have fertility issue, that's when they talk about it. That they've been trying, they've not been able to, or the men will say, I've had so many girlfriends, or I've been married, so, we've not had anything, or no woman have ever told me they're pregnant by me, or the woman will say they have problems. Fertility issues are huge ones. And yes, we do ask. Thank you, Dr. Famuyiwa. That's why, you've seen that we diagnose some and send them to get care. We send them your way to get care because that's our expert. And by the way, I want to ask on this forum, please private chat me, email me. So let us know what topics you would like us address that we've not addressed, or you want us to address again, to dig deeper, especially in the fertility arena. Please let us know. In all arenas, fertility included, is really what I should say. Thank you. So, Dr. Booker, kindly unmute.
Yes. Hello, my
How are you,
usual
sis?
Monday. I am good. In terms of wellness, I didn't think you touched on immunizations.
Ooh, I didn't.
Yeah, so I get all my immunizations. Luckily, you could get it from CVS or Walmart. Mm-hmm. In terms of anesthesia, you could ask if there was any problem with any family member had a bad reaction to anesthesia. That's thinking about malignant hypothermia. And you would hear them say, well, they had to stop anesthesia, or they had a fever, or it may not be MH, but it's good to find out. And the recent thing that's happening now is with propofol, are they allergic to eggs? Because it's the white of the eggs that could cause an allergy to when you get propofol. So that's really important. My friend in London, that she told them she was allergic to eggs and they still give her, and she had a severe anaphylactic reaction. Okay. So that's something that we should mention. And that's all I have to say. Thank you.
Thank you so much. Immunization, thank you so much. Immunization is another part of the well visit. That is the honest truth. So with immunization, we are in the flu season. So we ask that a lot. Would you like the flu shot? And some patients do, some don't. The egg allergy that you're talking about, Dr. Boka, the same thing with the flu shot. If you have egg allergy, we don't give you flu shot. That actually is something that will exempt you from. So we ask, and I didn't mention it. I told you there are points that I should have mentioned. Pardon me. We do ask for allergies. If you know things, your medications you're allergic to, is part of the well check visit. And some people will tell us about their food allergens, and the egg is important, as we've mentioned in 2 places now. Then, the pneumonia vaccine for older folks is very important. There are 2 types now, and the 13 and the 23 valent. Just remember 13 and 23. Talk to your doctor, and they will let you know when to get each one. Then the varicella vaccine, is another one. People ask me all the time if they should get the Shingrix. And I always say yes. COVID vaccine, my feeling is that COVID vaccine is going to become like the flu vaccine. We'll see how it rolls, but that's probably what would happen. But vaccines are very important. The Tdap, tetanus, diphtheria, and pertussis. Thank you so much, Dr. Booker, because a few years ago, I think it was about 2-3 years ago, not too long ago, we found out that there's a resurgence of pertussis. Pertussis is whooping cough, very bad in children. But guess what? In adults, it causes cough that is, I call it embarrassing cough. Patients who come and they say they're in church and they just start coughing. Well, they cough. That it becomes embarrassing. People are looking at them, they can't stop. Or they're in a function, or at the bank, the grocery store or something. They just start coughing. They have these cough spasms that they cough. It's pertussis. And it was suggested then that we should start re-immunizing people with DTaP. Tdap is what we give adults. It's a combination vaccine that has the tetanus, the diphtheria, and a cellular pertussis, the Tdap. We started re-immunizing people. You really should get this shot every 10 years. So if you have not gotten Tdap in 10 years, please get it. You don't want that cough. There's a cough going on around now. I'm telling you, it's around now. It's not COVID. People are negative for COVID. They're negative for influenza, but they cough. And this cough is lingering. It's most likely pertussis. The treatment is simple, Zithromax, but sometimes you have to treat 2-3 times before you clear it. But getting the shot is protective. If it's been over 10 years, again, I repeat, the tetanus is important too. You never know where you get a cut that may get you into trouble. But if you are immunized, then you are safe. So please get those shots and discuss with your primary care doctor what other shots you could get. My sister Naomi said also we should ask if the patient is safe at home, thinking about domestic violence. Sister Naomi, that one's a tough one. I said it before. I've missed domestic violence, and I'm ashamed to say it because people don't talk about it. It's difficult to ask, is somebody beating you? Are you going to say that? Are you being abused at home? There's physical abuse, mental abuse, emotional abuse. We as healthcare professionals are the ones who have to be sensitive to the patient's body language, the way they relate, and then be able to ask that question. But that's a huge one, and it's an important one. And if there's anyone on the platform who is experiencing this domestic violence, please reach out because we have resources. You should not be abused. We have resources and we can help. So Sister Mary is writing, in line with depression, that questions like, have you wished you were dead or wish you could go to sleep and not wake up, are questions we ask. And we ask those in those formats to evaluate for suicidal ideations, to see if somebody is thinking about it. So Auntie Tower, go ahead and unmute, man.
Good evening, everyone.
Good evening.
My question is not much. You were talking about DTAV, diphtheria.
No, DTAP, P as in Peter.
Okay. So you said something about Zithromax.
Yes, ma'am.
Yeah, I'm allergic to it. So what's the alternative medication to this?
There are alternatives. I'm sorry I even mentioned Zithromax on this platform. I would abstain from talking about direct treatment on the platform. So if somebody has pertussis or they have this cough that is not going away, it is important to see their doctor and then they will get treated.
Okay, I take that. Thank you.
Thank you, ma'am. That was it. Your questions are usually longer. And it's always like in multiples. I was ready because you will say, I'm not done. I have 3 questions, I'm not done. So I just don't want to go into medications on the platform because I don't want somebody to put their doctor on to say, oh, Dr. O said this, and that's not what they have.
And about the mammogram, if one has family history of very bad history of breast cancer, can they start before 40? Because I started mammogram at 38 and I still do it. Actually, I do 6-month mammogram, 6-month MRI, and ultrasound now.
Yes. So we are actually, unfortunately, this is so unfortunate, diagnosing breast cancer earlier than we used to. Let me rephrase that. People are getting breast cancer earlier than we used to see it. So how do we diagnose? Feel a lump. The patient is usually the one that finds their lump. Please, it is important to do that monthly breast exam. They find it, we do mammogram, no matter what age. At that point, they have cancer and we deal with it. So what is specific for you is what is being done, and it is important, and it is life-saving. You know, one size does not fit all in medicine. It's not possible. That's why, you know, I think I've mentioned tonight that, you know, it would depend on how, on that particular person, but these are general things that we do. And, you know, I'm going to stop for a minute and just show this, and I hope I can. Breast exam should be done by every woman a week after the menstrual period, if you're still menstruating every month. If you do it before the menstrual period or after the or during the menstrual period, if you have something called polycystic breast syndrome, you will feel lumps and it would worry you. And it's nothing. That has to do with period. That's or the menses. So that's why you wait a week after your period to do your breast exam. For women who are postmenopausal, pick the time during the month and do your breast exam. You can do it standing in the shower or lying flat on your bed. You lie on your bed with your hands like this. That hand is tilted back, is to stretch that muscle there so you can feel deep into the chest. In the shower, you do the same thing. You put your hand back there, and then you use this hand. The tips of your fingers is the tip you use. Think about it. If you use your hand flat, you may not feel lump, but when you use the tip, you can feel something. If it's there, roll under your fingers. And you start with the bone over here, this bone called the clavicular bone, the bone right there in the neck. You start with that bone and you go deep down, round, in a circular motion, down and up, and you go around with the tips of your finger to check to see if there's a lump in your breast. When you're done with that, still with your hand up, go under the armpit, and with the tips of your fingers, check under your armpit to see that there are no lumps there, or there is no lump there. Then go to the nipple and squeeze the nipple. You should not have any discharge. If you are not breastfeeding, you should not have milky discharge. If you have bloody discharge, then you should not. It needs to be investigated. So you squeeze the nipple, and if there's any discharge, then that needs to be investigated too. I hope that helps. If somebody doesn't know how to do breast exam, Auntie Tawa, does that help? You will know. Does that help?
It does. It does help. That is what you need to do. Whether you are postmenopausal or you are still having your period, you need to do it regularly and often so you can be safe. The only thing, you know, some of this breast cancer is not genetical. So how could one get a test like Braviac, or what is it called?
BRCA 1 and 2.
Yeah.
Okay.
Because
So
most of the insurance doesn't cover it if you don't really have the family history. And at times I did it for free, and they found that we don't even have it, that it was a mutation. But I've had 3 members of my family that came up with breast cancer. 2 of them are dead, 1 is alive, and the one that is alive is a doctor. She didn't even know if she has anything until it came out.
So insurances will not cover it, and it makes sense because we're careful with testings. You don't want to go and just be doing all these random tests. It causes trouble. Okay, it causes problems. And another thing I didn't talk about yet, I have to make a note, is the men PSA. I didn't get to that yet. So in order to do the BRCA1 to gene testing that you just said, people have to have counseling. Because what if it is positive?
Yeah.
Then what next? So they have counseling first, and there has to be reason for it to be
asked for it. I asked for it. It's not that my doctors, I asked for it, because if this thing is running in my family, I want to know whether we are genetically prone to it or is a mutation. So I asked for it.
So when you were diagnosed, it was not done?
I was never diagnosed. I've never had breast cancer. It's only everything I've done is preventive.
Okay, got you. So because people have had it was why you asked for it.
Exactly.
So we, on this platform, we actually have the resource that was introduced to us, if you remember, by the rep who came, that you can do all these genetic testings. It's very comprehensive. It's not just breast, it's prostate, it's colon, it's everything. And it said, remember we were asking how much would it cost? Because we don't know if insurance will cover it. How much would it cost if one wants to pay out of pocket? And he said it was $200 and something. Is it worth it? I think it's worth it for one to answer such questions. So that would be a test that may be helpful to do. And, if you check your email, that's in there, or I can send it out again, but there's a company here in New Jersey. He's been trying to link me up to the rep in Maryland, but has not been able to successfully do that. I don't know if they have a rep here.
Thank you.
Thank you, ma'am. My brother Sam Togo, all the way from London. Do you know what time he is now there? And he's still awake. He has complained about the time we do Medical Mondays because it's in the middle of the night over there. Hi, brother. He says, how would he know if he has egg allergy? So here, with this testing, food allergy testing that can be done, and it will show if somebody has egg allergy. And if you have allergy and you eat eggs, you will react to it. That's another way to know. That every time you eat egg, something happens. You break out in rash, or your nose starts watering, or what have you. If you are attentive and you are able to nail it to what is causing your allergy, then you'll find out that, you're not tolerating that thing. So that's another way to find out. But there's testing for it that we do all the time. So there's a question here that says, does the gerontologists utilize a different scale in their evaluations? No, they don't. But it's very interesting that this question is not publicized. But Dr. Ezugu wrote 4 risk assessment 2, especially for 65 and older. That's huge. And we do that to evaluate risk. We ask questions, even like, do you have stairs at home? And if you do you have banisters to hang on to go up and down the stairs? How are the floors? Do you have carpet? How is it? Then the patient themselves, how stable are they? Do they use walking stick? Do they need walking stick and all of that? Gerontologists focus a lot on that. And we do too, to some extent, but I don't think we do as good a job as gerontologists do for the older folks. There's something else that I didn't mention apart from the PSA. PSA is a test that was standard in routine well check for men in the past years. And before then, rectal exam, I remember the days of rectal exam. I used to hate them. You know, sticking your finger in the rectum of a man during visit. It was standard physical. I used to hate it. And when I had medical students, I kicked the medical students to do it. Because, you know, I just didn't like it. And, you know, and we do that with the PSA. But now rectal exam has been scrapped. We don't need to do it again unless a patient comes in and they have complaints in that rectal area. Then, of course, they'll be examined. And PSA, it is recommended that we don't check PSAs routinely anymore because it's been leading. See, Auntie Tawa, this is the thing. It's been leading to unwarranted procedures. And no procedure is benign. So unless there are symptoms, we don't routinely check. But when I have male patients and they ask for a PSA test during their well exam, well check, I check it. And I've not had any problems with the insurance. Dr. Craig, go ahead, sir.
Unfortunately, the insurance system almost requires a digital. First, you'll get a lab, and you'll see that the PSA is past its point. And then the insurance will say, we will not allow any procedure, whether it be laser, whether it be surgical, whether it be something else, to occur unless we have a digital result. And that is, well, to me, it's, as a man, it's outrageous, basically. But that's the way the system is right now. And they will not allow any exam at all, any surgical, any procedure to occur at all without the digital. Now, it's most doctors don't want to do it at this point. But if treatment is needed, and usually treatment is, if the PSA, if the PSA is 5 or above, usually, you have to go through it at that point. So it's real. It's a real problem. And I understand you're not wanting to do or your distaste of doing it at this point in time, okay?
Well, I still do it. I do the needful.
Okay.
You know, it's just, I do the needful. I do whatever is needed for my patient. Mm-hmm. And some men ask for the rectal exam, and that's fine. I'm also now, I find it easier to send patients to GI doctors and let them handle it. So that, because they have the recent protocols, processes, and they can easily navigate with the patient. So I just send them to GI doctor if I need to. And my sister from California, Sister Wumi Kamsin, said that they need to come up with, or we need to come up with, an easier preparation for colonoscopy. That'll be a hard one. You got to clean out. I don't know any other way to clean out than to clean out. You have to
maybe a pill, a tablet or something that will make you
we
clean
have
out
that.
all that junk that we drink. Because I usually do the liquid one.
But we have that.
Oh, okay.
We have pills. I am talking about the process. I'm talking about the process itself.
Exactly. Yeah. And that's what I'm referring to the actual process of drinking that liquid for so long. And
Yeah, that's the go lightly. So
Yeah.
it's a preference now. Some people actually prefer it. See, I'm glad we're having this conversation because your next colonoscopy asks for pills. We have pills. I've never taken the liquid form.
Oh, okay. I've never been prescribed the pills. They've always given me the option of not option. The only choice I had was the liquid. So I guess I can ask my doctor then for the pill. Okay.
Yes.
It's nice to know.
For the pill. Yes. And
nice
they give
to
you
know.
the pill. Yes, we have the pills. Yeah. But it will still do the same thing. You're still going to stay up all night, to clean up.
And go through the motion.
Clean up. You still have to go through that motion, which is not bad. You. It's only one night.
Yeah, I hear you.
Yeah.
It's all for good health. Health is wealth, right?
It is. Health is wealth.
Health is wealth.
Yes.
Thank you.
So, thank you. There's one thing, and I'm not going to say one more thing because I might have missed some others. Advanced care planning. I ask usually my patients who are 50 and over that if there's anything that happens that causes them not to be able to make a health decision for themselves, who would they pick to make that decision? It's called power of attorney. And I ask this thing and I write it in the chat during well visit. And every year I would ask again the same question. If anything were to happen to you and you cannot make health decisions for yourself, who would you pick to make it? And they would tell me, if the person remains the same, I note it. If they change, I note it. And I update the date that I did that. I also give my patients a package to fill and sign it, writing the name of the person, the address, phone number, all of that information that may be needed. Do you know that a couple of years ago, I needed it? A patient of mine called me. Husband and wife are my patients. The wife called me. The husband passed out in the bathroom. Long story, they wanted to turn everything off. Wife doesn't want them to. They said, well, she doesn't have the power of attorney. They don't have one. She said, let me call his primary care doctor. Dr. O, do you have anything like this on file? I said, yes, I do. One of my staff actually helped him fill that form that day. Some of them would take it home, bring it back. Some don't. I put it in the chat, what they say. So I called the hospital and they asked me to fax the power of attorney that he signed, that we kept in our records, to them. And I did. So the wife was able to take over. The man is still alive today. A simple power of attorney. Questions, a few sheets of forms filled, saved his life. And that was at the well visit. So that's something I did not mention before. So Ms. Rochelle Shokoti said, what about a healthcare proxy? Isn't that also needed? Thank you. I think that's what we're talking about here. I hope that's what it is. Yes. Thank you, Dr. Craig. It is called power of attorney. That's it. That's what we just talked about. Thank you so much for that question. It was timely. Dr. Izugu, go ahead.
Now that's a very important area of discussion with patients. Many of us, when the patient comes to us for cardiology, usually when we bring up the topic, they always say, am I about to die? but that's not the essence of that. It's just part of natural planning. So we'll bring it up in front and just discuss that, is so that decisions will be easier for you, for your family, for anything. It doesn't mean that you're going to be dying tomorrow, but it's just an important record to have.
Yes.
So I would encourage even having that discussion as often, even in the family area as well, even just making those discussions, because you just never know. You just never know. It's very important.
It's very important. Thank you so much. And it is not living will. Living will is different. Living will is the attorneys on the platform can comment on that, but it's different. Sister Tina, you can unmute.
Yes, good evening. So I just wanted to add to what you said. For those people that have parents living with them also, it's also important that you get a power of attorney from them. Like my mom lives with me, so I have a power of attorney from her in case she gets into issues in the hospital or stuff like that. I'm able to take over, even though I'm the only child. But the power of attorney helps to make sure that they carry out our wishes. So I thought I should bring that up in case people have parents that live with them.
So you have it already, right?
Yes, I do.
Fantastic. Fantastic. It's very important. And even for us, you know, something just occurred to me. I need one. My doctor has never asked me for one. So when I go next, I'm going to ask my doctor to please record my power of attorney. We all need one. Satina, you're talking about your mom. You too need to have your power of attorney.
Yeah, I do.
Wonderful.
So it's can I make a comment here actually? Dr.
Please.
Oh, you make an important point here, because some of us have it, but we have it either with a lawyer or it's locked in our safe box, but not with our primary care. We can mention to the primary care if it's available. But I think it's really important, because that's the one somebody's going to be calling to say, does the patient have any wishes that you have on record, or, you know, all those things. So I think bringing it to the primary care doctor is extremely important. Yes.
It is important. Thank you. And, I said, okay, what you need during well check, that's the topic of this conversation, but what do you need to ask? Those are the things that we need to ask. Thank you. Thank you, Dr. Izugu.
Sure.
Sister Wumi, go ahead, unmute. Oh, Sister Wumi.
I believe if you have estate planning, a power of, I'm not sure what they call it again, but that power of attorney is also included. So for people that have estate planning, because you also have the living will, it's called trust. I think it's called trust, living trust. The power of attorney is included in that documentation.
But guess what? God forbid it's needed. It's your primary doctor that will first be called. It's important during your next.
That they have a copy of it.
That they have a copy of it. I have a copy of some of my patients' living will or what have you. When I ask them, they say, "Oh, I have a living will. I'll bring you a copy." Some volunteer it already. Some I say, "Do you mind giving me a copy so we can scan it into your chat?" And once they do that, I put it right there in the chat so that immediately I open the chat, when they ask me about the patient, I can tell if this person has it in their record or not and be able to help. So a question here or a comment here says, often an advance directive is completed at the same time as a healthcare power of attorney. Now, advance directive is different. It's the advance directive is the comprehensive, the umbrella name, I believe.
That was the word I was looking for. That was the name I was looking for.
Advance directive is the umbrella, I believe. Then under there, you have living will, you have power of attorney, you have different, things under there that says, similar things, but, they are different. And different people are the ones that can do those. There are some that only lawyers can help you put that together. The ones we are talking about, it's a form and we scan it in and I've seen it, you know, that it has changed somebody's life. It's very important. Do we have any other questions? Man, this is an amazing family, I must say. Thank you all for filling the gap.
Thank you, Dr. O. Thank you.
Thank you. Oh, Dr. V, you are too awesome. Thank you.
Great job.
I appreciate you. Dr. Opesanmi, all the way from Nigeria. Thank you. Thank you. So I'm sure you are happy about, you know, us talking about getting the dental checks.
Yes, to make it complete. Yes. Thank you.
Thank you.
Dr. O, this is Dr. T from Massachusetts. I wanted to clarify something regarding the power of attorney and the healthcare proxy that you mentioned. In Massachusetts, when they refer to healthcare proxy and the other ones that you mentioned with the lawyer, is referring to the lawyer. But in the hospitals, they call it the healthcare proxy is what you were describing. So when you go to, all the hospitals, or if you go to your primary care doctor, they always ask you if you want to fill that form. And when you fill it in, they will add it to your records like you do over there. So there is another document which is the power of attorney. And that usually talks about financial things that live with your lawyer in case of estate planning. So yes, so if you have a client from Massachusetts, maybe you should mention those two, healthcare proxy and the power of attorney. So they may have the power of attorney, but the doctor may not know anything about that. So the healthcare proxy is the term that is probably common over here. For what you're referring to.
Thank you so much for that clarification. And Sister Rochelle actually wrote the same thing here, that healthcare proxy grants the authority to make medical decisions, and the power of attorney grants the authority to make financial decisions. In our charts, what we have in our charts is power of attorney, and it has living will. It doesn't even have healthcare proxy in our electronic health records. We can hear you. You are breaking up.
That's why she clarified.
You're breaking up. So in Massachusetts, I get it. And you know what? It may even be the same in Maryland. Law is not my strong point at all. I just know that in our electronic health records, it has that power of attorney. And when I click on that, I can now put who they have picked as power of attorney. And that was what worked in this patient that I was talking about.
So
I will look more into that to see if, you know, it's different in Maryland is why. I'll look into it. Sister Tina, go ahead.
Yeah, so what I have for my mom is a power of attorney, and it explicitly talks about healthcare in the power of attorney that I have.
That's the one we have too. The power of attorney we have, it talks only about health, nothing about finances.
No,
exactly. That's why I said I'll look into it. Massachusetts may be different. I don't know.
Yes, Dr. O. Miss Shoko.
You're breaking up, bro.
Maybe that's why.
You're breaking up. But I think you're trying to say that it is different.
No, what I was saying is that Miss Shokoti is also in Massachusetts. So that is why she's explaining it that way, probably.
Okay, got you. Got you. So the forms we have that says power of attorney, actually, it's all about health. Nothing financial there. But I'm not an authority on that. I think the message I'm trying to drive home here is that make sure with your primary care doctor that you have in place something like that, that is appropriate for your state, that states who, God forbid something happens, who would know exactly what you want done. Do you want everything turned off? You don't want to be on any machine, or do you want your life to be fought for? Basically, that's what that answers, but the person who can make that decision. So Auntie Tawa is asking, do you do their medication reconciliation? Oh, yes. Thank you, Auntie Tawa. During the well visit, definitely I do. And that's, most of us would do the medication reconciliation then. Although we continue to do it through the year because things change during the year. But during well visit, it's one of the most important components to do medication reconciliation and make sure that we know what the patient is on and what they should not be on and all of that. Thank you. So, Kiani, I'm waving to you. Kiani, can you see my hand? I'm waving. Kiani, I'm waving, and I want you to know that I love you so much. Kiani is one of my closest friends, sister, friend, granddaughter, and she's been waving to me, but she didn't know that I didn't see it. So I'm waving back. Okay, Annie, I love you. Thank you for participating in Medical Mondays. Love you, baby. Any other questions? Well, I want to remind us again that on this platform, we don't establish physician-patient interaction, but we share medical information. I want to thank everyone on the platform for even being here. The physicians, healthcare providers, here we have everybody. I'm looking at Auntie Tawa, Dr. Craig, Dr. Izugu, Sister Tina, and Sister Umi, Sister Rochelle, Dr. T, everybody that has participated. I'm calling you out by name. We did this together. You know that? Sister Mary from Virginia, Dr. and Dr. Ajay, Brother Togun from London, Sister Naomi, Dr. Famuiwa, Dr. Buka. What Dr. Buka said, still hits me. It's very, very important. Everything we've said tonight is important, but that egg thing, very important. If I miss your name, please correct me right away. Thank you so much for putting this together, because we did this talk together. Thank you. And my brother from London, is a minister actually, Togun, said, thanks to the various doctors on the platform. And before we conclude tonight, I want to encourage us to please be careful during this holiday season. Let's be careful of COVID, the flu. The flu is raging. I say this every week this year. And that cough, I'm seeing a lot of people coughing, and they're telling me that they've been coughing for a while. The cough has been going on for months. It's most likely pertussis. Please be careful. Get immunized. It's important. Oh, my brother Togun, thank you. He invited me to speak to the elders at the Nigerian church. And that was a while back. So It's alluding to that on the platform. It was a privilege. I enjoyed talking to the elders. Thank you for the invitation. So I want to remind us also that please, if you're interested in any topic, let me know. You can email me, you can text me, and let me know, and we'll make it happen. If you want to talk, let me know. We can dialogue. We can dialogue, and I'll be glad, for you to come educate us. We learn every week on Medical Mondays, and we thank God for the knowledge, for how we've been able to change our lifestyles to be better, to be healthier. I feel like I've been healthier since we started this platform. I've learned so much. It's amazing. I'm telling you. See, no, seriously. I went somewhere yesterday, I was saying it, and I saw a lady, heat up a sauce in plastic. So I knew not to eat it. And I saw the other sauces in the plastic, and I knew that they would have poured in there when it was hot. Now, in case you were not on this platform when this was discussed, Dr. Craig, do you remember discussing this?
Yes, I do.
When we're talking to the naturopaths, can you talk about that really quickly, really briefly? Not to pour things in.
Very quickly, we should never, ever heat anything in any kind of plastic, because that plastic, if you want to see, take some plastic wrap, wrap it around something, an apple, and put it in the microwave, and you'll see it will drip. The plastic will actually drip. And that drip is going into the food. And when you eat that food, that is going into you. And our bodies do not process plastic at all. Very dangerous. Some people do it all the time. And unfortunately, they haven't learned the lesson as of yet. Spread the word. Do not heat anything plastic in the microwave.
Thank you. Thank you, sir. And Dr. Gillum told us, when you finish cooking, you know how you want to store your food in the refrigerator? She said, do not pour that hard food into plastic, because the plastic, what do you call it, Dr. Craig? What they used to make the plastic seeps into the food.
That's correct. And it actually decomposes. We don't see the decomposition because it's too small, but it is in the food.
So she said, let your food get cool, and
Room
then
temperature.
you can store
Yes.
it in plastic if you want to, but it has to be cold when you do that. Or she said, put it in a glass container. You can put it in the fridge anywhere, let it cool. And if you want to pour it in plastic, you can after that. So I don't know, for whatever it's worth, for whoever needs it, the Lord made that happen for us to discuss it. Sister Rochelle wrote here, it's BPA. Thank you so much. See, BPA is what seeps into the food, and it's carcinogenic, right?
Yes.
We've seen a lot of cancers. We won't get it in Jesus' name. Thank you so very much, everyone. Until we meet next week, continue to eat those leftover turkeys. Don't warm them up in plastic, and stay safe.